Hey guys, and we welcome back. We are going to now go over the foot. So you should have at this point watched the both videos on the ankle, the anatomy tutorial and then my screencast. And now with the foot, you should have already watched the foot tutorial that is about 8 minutes long in the same folder, and now following it up with the screencast. And then on Tuesday in class, we're going to pick up from where I leave off in the screencast and go over any questions that you might have. So let's jump into it. I'm going to again use the same PowerPoint that's in Blackboard for reference. We're just going to skip down into the foot related things, as we already covered the ankle. So I want to start on slide 6 if you're following along. And this talks about the architecture of the foot. We hear a lot of times of, my arch fell in my foot, or I have bad arches in the foot. And typically when people are referring to the arch of their foot, they're referring to the medial longitudinal arch, which you can see on this picture is this A through C right here. And that's the big arch that when we look at the medial or the inside of our foot, it's that rounded concave shape that we see and is most noticeable when we're non-weight bearing. Oftentimes, especially if we pronate our foot, or it's also called pes planus, or the foot kind of drops, we lose a lot of that really significant arch. We talked about foot pronation, supination in the ankle video, so if you need to refresh yourself on what that means, go back and check that out. It's important to note, though, that there are two other arches in addition to that medial longitudinal arch. The first one, we look A through B here, and this is right at the base of the metatarsals. So we have the first metatarsal here, if you can imagine, second, third, fourth, and then the pinky toe has the fifth metatarsal right in that midfoot area. And this arch here that kind of causes a concave shape in the metatarsals is called the anterior transverse arch. We also have a lateral longitudinal arch, B through C, so that's on the lateral side, not as pronounced as the medial one. If you look at the outside or lateral aspect of your foot, you won't see as pronounced of an arch. It's kind of tucked away past the cuboid and the fifth metatarsal, especially that styloid process at the base of the fifth metatarsal, come out a little bit further, which is why this one is not as pronounced. But those are the three arches of the foot. You have three, not two. And just as review, the foot and ankle, we'll call it, has different movements. The talocrural joint, which is the articulation of the tibia, fibula, and talus, is responsible for dorsiflexion and plantar flexion. That's our traditional ankle joint. We also have the subtalar joint, which is the articulation of the talus and calcaneus, so sub, below the talus, talus and calcaneus. And that is responsible for the inversion eversion. It is also contributing to pronation supination, but as you remember from the other slide, or from the other video, excuse me, pronation supination encompasses more than just inversion eversion. So this slide is a bit misleading. This is directly from the book, which is why I wanted to leave it as is, but I wanted to explain that difference, where that pronation supination is not just the subtalar joint, but also includes the midfoot, which are those 5 tarsal bones we'll get to in just a minute. The other big movement in the foot region area is toe flexion and extension. Now remember, we've got the 5 toes, but the first, sometimes called the great toe, also sometimes called the hallucis, has the different name, and then you'll name the others accordingly. So the first toe, and then the second, third, fourth, and the pinky toe, or the most lateral one, is the fifth. Let's take a look now at some of the specific bones of the foot. We've got the talus right here, and we can't see it because it's been removed, but normally the tibia would sit right on top of there, and then on this lateral side here would be the fibula coming down, but those have been removed, so we get a nice clear picture just of the foot. Interesting to note that calcaneus, so we see the subtalar joint, or at least the side of it here, but the tail is sitting on top of the calcaneus. This is our subtalar joint. And interesting how far back the calcaneus goes. We talked about this in the other video too, and there's a nice picture on the next slide where you'll see that lateral view where you can just really appreciate that that talus is really sitting pretty far forward on the calcaneus, and then you've got a big chunk of bone here where then in the very posterior aspect here is where you've got the attachment of the Achilles tendon. Midfoot here, we have the collection of the 5 bones that we are calling the tarsals. So it's been labeled right here. Tarsals include, right here is the navicular, the cuboid, which is shaped like a cube, that's where it gets its name, and then our 3 cuneiforms. We've got the lateral cuneiform here, the middle cuneiform, and then the medial. I think it's a big misconception that with the cuneiforms we hear lateral, middle, medial, and a lot of people think that the navicular is more medial than all of them, and these are in the middle, but you can see how the cuboid and the navicular do touch right here, and then those cuneiforms are distal to the navicular. Important to remember when we talk about ligaments in just a moment. From those tarsals, we go down into the 5 metatarsals. So we're here on the inside, we've got the great toe or the hallux is here, so that's our first metatarsal, and then we go all the way to the 5th metatarsal, and we see that here. At that base of the 5th metatarsal, we see that in a pointy area, and that's called the styloid process. We're going to jump back into that in a little bit and talk about some injuries that occur to that styloid process, because you can see it is prone for injury. It just kind of sticks out there. This is where, if you can imagine tendons and muscles being laid on top, this is the lateral aspect. So these are those perineal tendons we talked about that come down. Perineal brevis would attach here, and the longest hooks right about here, goes underneath the foot for its attachment. After the metatarsals, we go into the phalanges, and these, when we look at our foot, these are the toes, and we've got a bunch of bones that make up this area. Let me see. I've got another, here it is. Here's a good picture. So when we talk about the phalanges here, we've got the proximal phalanges here. So these are the metatarsals. Then we go proximal phalanges, and we've got 5 of those right here. When we talk about a joint, this would be the metatarsal phalangeal joint. Metatarsal connects to the phalangeal joint of the 1st, 2nd, 3rd, 4th, 5th. That these are our proximal or closest to the body phalanges. From there, we have middle phalanges. And the important thing to note is the great toe does not have a middle phalange. So it's 1 bone short. Whereas the rest, you can see the middle phalanx or middle phalange, but the middle phalanx on 2 through 5, but not on this first one. Important to note that. So the great toe has 1 less joint than the other 4 toes in our foot. The reason for that is the great toe is because of its larger size, it's more, it serves more function in the foot. It needs more power as far as the musculature. So we sacrifice some mobility for stability. These toes have a lot more movement and aren't as stabilizing as the great toe. So when our bodies were designed, it was thought, okay, we need a lot of movement in that foot, but we've got to have our stability somewhere. So most of the stability comes on the 1st, and then also the 5th has quite a bit of stability, but really the 1st takes a lot of that forefoot stability. And then we've got the mobility, less restrictions in these toes. There are 5 distal phalanxes. This is like the very, very tip of our toe. The toenails are on top of these distal phalanx as part of the phalanges. And so again, just remember that great toe just has a proximal and distal, whereas the rest are going to have proximal, middle, and distal, difference in the foot. This is an x-ray where you can see the difference in the phalanxes as well, looking all the way back up here. Now we've got the tibia and fibula coming down, talus right here, and the calcaneus. Got our nice navicular, cuboid, and then our cuneiforms, metatarsals 1 through 5, proximal phalanx or phalanges 1 through 5, our intermediate or middle 2 through 5 only. That's A, B, C, D labels. And then these are our distal ones right there. You'll see some discrepancy between the first and second toe as far as the length goes. I think the latest statistic is about 25% of the population, their second toe is actually a bit longer than their first, and this is called a Morton's toe. And with a Morton's toe, it's just something they're born with. It's not doesn't serve that much of a difference in foot function. There might be a little bit more weight that's distributed onto the second than the first because of the length difference, but it's just one of those abnormalities that happens in about 25% of the population where they get that Morton's toe, whereas in 75% of the population, that first toe is the longest one, and then they kind of taper down from there. So there's your fun fact for the day. So we've got those that I showed you. Another fun little thing to look at. So I'm a big person of fashion over function, and I'll make sacrifices even when my feet hurt to wear cute high heel shoes. So that's an x-ray of what is happening with the foot in a big stiletto heel right there. You can see how the weight is certainly distributed, coming straight down through that ankle joint, which is in extreme plantar flexion. Like, that's pretty impressive, actually. They can even get to that position. And then we've got the navicular cuneiforms coming down here, and that weight's going right through those. And most of that weight is right there on the head of the metatarsals, which just, oh gosh. So you can imagine when this individual takes those shoes off at the end of the day, she's going to be rubbing the forefoot because, oh, that just took a ton of weight through the whole day, and really not a lot of weight on the calcaneus. We've got a loose tension on the Achilles tendon, which you can't really see because it's an x-ray, but not a lot of weight distribution up here. It's all coming down here. So interesting to look at what we're doing to our feet in a really, really high-heeled shoe, but hey, they look cute, so a bunch of us girls continue to wear them, I guess, right? Jumping back to our PowerPoint here, I'd like to look at the lateral view. Oh, sorry, this is medial. Oh, that's fine. We'll go medial. Here we can see a couple of different things. Again, calcaneus and talus here. We would have the tibia on top here. Now we've got our medial cuneiform is what we can see. This would be the middle cuneiform. We see just a little bit of it, and then we don't see the lateral or cuboid. But we do see the navicular here. First metatarsal, and then you can kind of see a little bit of the second, and then the phalanges. We've got the proximal and distal phalanx there. Important structure to point out on the calcaneus, we've got a little notch right here. It's a bony prominence. It is part of the calcaneus, and it does, on the superior aspect here, does articulate with the talus. So it's one of those areas that does touch, and it's called the sustentaculum tali. Sustentaculum tali. And this is significant, not just because it articulates with the middle area of the talus, but we have, remember those 3 tendons that come down and wrap around that medial malleolus. So you can imagine the medial malleolus would be right in here of the tibia. And remember we talked about Tom, Dick, and Harry, the 3 tendons coming down. Well, the flexor hallucis longus, which would be the hairy of that group, actually wraps, and the inferior border of the substentaculum tali is where the flexor hallucis longus comes and hooks around and then goes down to that great first toe. So that's a significant area. You can, if you really know your anatomy well, you can actually palpate or feel the substentaculum tali on your own foot. Just go distal to the medial malleolus, right below it, or you can start on the base of your foot here, calcaneus, and when you kind of go up in line with that medial malleolus and feel a bump, that's what it is. So sometimes it's a bit sensitive when you push on it hard, so watch with that. Not to be confused with the navicular tubercle here. The navicular bone, which is one of our tarsal bones, does have a tubercle or a spot that comes out. So sometimes these two, the substentaculum tali, which is part of the calcaneus, or the navicular tubercle, do get confused because they're both little areas that that do come out on those bones on the medial aspect or inside aspect, and they're pretty close together. So those are those two. Remember the trochlea of the talus, that's where that articular cartilage lies, and then the tibia would sit down on top of it, and that's the smooth gliding surface that we get that plantar and dorsiflexion, and that's where we get the ankle movement. All right, so from there, here is the lateral view or the outside view. And again, talus and calcaneus, so that's our subtalar joint right there. And we've got this perineal trochlea, again, lateral view. So on the medial view, we have the substentaculum tali of the calcaneus, and that's what that flexor hallucis longus hooked around. The perineal trochlea is that area that, and again, remember the fibula would also be right in this area that comes down, but that's the area that the two perineal tendons, the perineal longus and the perineal brevis, come around, hook around, and then the brevis would attach right there. This is the fifth metatarsal, and that's a styloid process, or the base of the metatarsal, and then the longus actually goes right in that little groove and hooks around underneath the foot. Nice view here, though. Now we see the lateral and middle cuneiform. The medial one's hidden, but it's back there. And then the navicular kind of comes across the whole foot there, but we saw it more on the medial side. Okay, moving right along with some of this. Oh, the one bone. Oh, hang on, I'm going to scoot back up to this one. One bone I didn't talk about. So there's 26 bones in the foot. And that includes the calcaneus and talus. But we've got these little guys right here, and these are not technically grouped in when we talk about how many bones the foot has, but these are sesamoid bones. If you remember, biggest sesamoid bone in the body is the patella, and these serve a similar function as the patella does. Most of us have two in our foot, just like that, in the great toe or the hallucis, right at the head of the metatarsal. Some people only have one. Some have no sesamoid bones in their foot. So this is a discrepancy. Again, it's like that Morton's toe of the second. Some people are just born with one or none, but most of us have two sesamoid bones in the foot. And the function of the sesamoid bone, I've got a good picture here. There. So the sesamoid bone right there, this is the head of the metatarsal, and then we go proximal phalanx, distal phalanx. So this is all the great toe. It's not like you're looking at all the toes together, but it's showing you that flexor hallucis brevis muscle comes in, and this is the flexor hallucis longus tendon, which goes to that distal part of distal phalanx. And the sesamoid bones keep the flexor hallucis longus tendon in line and running in between that brevis. So again, brevis is here, and then it kind of comes through the middle, and those sesamoid bones just find, I think of it like a bumper car, kind of. It just keeps it in line, keeps everything straight and working, and the angle of pull to go the same way. When we look at an x-ray, this is what they look like. they're not just floating there and could like go to other spots in the foot. Oh, this, see that little cloudy surface here? Totally got distracted looking at this. So this is the fourth metatarsal. That little cloudy surface means they have a stress fracture in that area. It should be nice and clear lines, but that's a stress fracture. So that's actually calcium building up and the body reacting to an area. So, fun fact, that's what we're looking at. But you know, as I told you guys, I worked in an orthopedic office before teaching. Frequently, it was kind of funny how many times we would put the x-rays up in the room of somebody that had foot pain, and I'm sure we all have done it. I certainly do it, but you know, before the doctor comes in, if you've got your x-rays up in the room, of course you're going to examine them and like try to figure out what's wrong before the doctor comes in. So we would have these x-rays up of the foot, and most of the time we'd walk in and someone would say, I see the fracture. Oh my gosh, it's right here. And they'd be pointing to their sesamoid bones, because it does. It looks strange, and most people that don't have the anatomy background aren't sure that they even have them, let alone what the heck those two little floating circles would be. So most patients think they're fractures, but in fact, there's the flexor hallucis tendon, longest tendon that would run right between those two, and then brevis is going to go on the side here. So that's what the sesamoid bones are. You can get a sesamoiditis. Remember, anything that ends with the suffix itis means inflammation of. So these can get inflamed, which you can imagine would be a really painful thing to get, because then every time you're stepping down on the foot, you're pushing on the painful area. So really difficult if somebody gets an inflammation of those. And sometimes it's an overuse thing. Sometimes it's just like a stepping on something super hard, or jumping down and catching them just the right way, and they get inflamed, and can be a long recovery just because it's hard to stay off your feet for enough time to recover all the way. Okay, so let me see where we're at in the PowerPoint here. Going back, we already covered ligaments of the ankle. I'd like to jump down. Oh, here's a nice picture of the calcaneus, specifically that cestum taculum tali medial aspect, and then lateral aspect, we see the perineal trochlea. So those are the two bumps that are important for those tendons to hook around on both the medial and lateral aspect of the calcaneus, or the heel bone. I love this picture because, again, subtalar joint here. This is the talus, and then we don't see the fibula or the tibia here. But this really just shows you that about half of the calcaneus is not articulating with the talus. So we've got that big dip here, and then right about 2/3 of the way down the back here is where that Achilles tendon attaches and then comes up. So interesting view right there. Good to appreciate that. Okay. Let's jump down and look at some of the bones, specifically that navicular right here. Don't you love when you get interrupted by that? I'll have to call her back. Yikes. Sorry, guys. Anyway, navicular right here. And remember, the navicular tuberosity is that thing on the medial aspect here. Distal to the talus. And articulates, those are the cuneiforms there. There's the cuboid. And we'll look at the cuboid right there in a little bit more detail. Lateral most tarsal bone, even though that this is the lateral cuneiform, the cuboid is even more lateral than that. So important thing to note. The cuneiforms, first, second, and third, they're sometimes called, but first is the medial, the intermediate or middle, and then the third is the lateral cuneiform bone. And important to note that each of these bones, remember, ligaments attach bone to bone. So we've got tons of little ligaments between all of these. Here is a great picture of all sorts of ligaments when we talk about attaching the talus to the navicular, to the calcaneus, to the cuboid. Lots of little guys in here. The one that I really want you to pay attention to is this ligament right here, this Y-shaped one. It's called the bifurcate ligament. This is a really important one. They're all important. I mean, they all serve good function, but this is one that I can imagine would be on a test coming up in about a week, so certainly one to focus on. The bifurcate one is significant to all the other ligaments because it's this Y-shaped, and it's not attaching one single bone to another single bone. It originates on the calcaneus, as you can see, but it branches off, and it's a fairly thick ligament, as you can imagine, since its ability to branch. But one of the branches attaches to the cuboid, and one attaches to the navicular. So this is a really unique ligament in that it's connecting 3 bones rather than we normally connect 2 bones 1 to 1. So this is a nice picture looking from the top down. So we've removed the talus so that you can actually see the view here. But this is that calcaneus right here, and this posterior facet is where the talus would sit on top there. But you can see that bifurcate ligament originates on the calcaneus as one and then branches, and there's one connecting to navicular, there's one connecting to our cuboid. So it's a very unique ligament, and something certainly to pay attention to if that's enough of a hint for your next test. Other than that, we have some more ligaments. We've got the long plantar ligament. It's a ligament that runs, it's obviously long, you guessed that by its name. And a lot of these, the name gives away where they're running. It's just knowing, what all the bones are, and then it really clues you into what these ligaments are. But the long plantar ligament, plantar surface is the underneath of our foot, dorsal surface is the top, so it runs on the bottom of our foot in a long way like that. Let's talk about the joints of the body, and gosh, this is an intimidating slide, I think, because of all those ligaments, and you see all that. Again, they all have names. Most of the names are exactly what they're attaching, so that makes it fairly easy. You do not need to know every single one of these names for the exam, but you should be able to figure them out. If I'd say most of the time, if you just named the 2 bones, you got the name of the ligament correct. Same with the phalanges here. They're going to have collateral ligaments or side ligaments. Remember, we talked about 2 big collateral ligaments in the knee, the medial and lateral, also called the lateral is also called the fibular ligament. And those are the 2 on either side of the knee, prevents it from going in a valgus or varus manner. So these are hinge joints as well as the knee, so prevents it from going in that side-to-side motion or that distal segment to go varus or valgus. So the collateral ligaments all just kind of like mushed together, and they're pretty thick, so we think of them as part of the joint capsule in some ways, but knowing that they have, there's a nice example of the medial and collateral ligaments. But the only other, I want to loop back to one thing here. So with the metatarsals here, 1st through 5th, and we can actually see right there on that 1st a nice example of the sesamoid bone. But remember that base of the 5th metatarsal, how we talked about it kind of going out like that. This is very prone to injury, and there's something called a Jones fracture, which is actually a fracture or a break through that base here. And I've got a nice picture of a Jones fracture. It's right here. You see that little area in the x-ray that you see that darker line. This is the 5th metatarsal here. The styloid process coming off the base. Good view of the sesamoids also. But that little line should not be there. And that's a fracture or a break through that 5th metatarsal called the Jones fracture. It's a really difficult fracture to recover from, like I said in class today, or Thursday if you're not watching this today. It's poor blood supply, and based on some of the other stresses that go through that area, it tends to take forever to heal. This is one, normally when you have a fracture or a break in a bone, it's about 6 weeks for it to heal. Jones fractures, they start off saying it's probably going to be 12 weeks, and then it may not even heal after that. So those that it doesn't heal on generally get this nice thing, big screw put in, starting at the base and going straight down that shaft of the fifth metatarsal, and that will hold it in. It looks like this would cause problems, but in reality, even though the head of the screw is coming out right here, it's not butting up against anything. So that person would be able to walk normally. It wouldn't be like rubbing against anything. If you pushed hard enough in this area on the skin, you might be able to feel it, but most people would live with that screw in the foot like that for the rest of their lives. It wouldn't come out after the fracture heals. So that would be the treatment if somebody has that Jones fracture, which is a fracture through the base of the styloid process. As we jump down into the muscles of the foot, remember we talked about the 3 compartments of the lower leg, lateral, anterior, and posterior, and the posterior has subdivided into deep and superficial. Most of the muscles that are part of the ankle we've already talked about as part of these compartments. The foot does have a couple extra muscles, and these are called the intrinsic muscles of the foot. Take a breath and a sigh of relief here. I do not need for you to memorize every single one of the intrinsic muscles as far as origin insertion. What I would like you to know for the exam are that the intrinsic muscles of the foot, what is the main action of them? So if you focus on that, that's about as deep as we need to go for this particular class. But know that you can see the flexor digiti minimi brevis, the adductor hallucis, so it does have some adduction or bringing it back to the body at that joint, so it's not just a straight hinge joint there, which is important to remember. But lots of little intrinsic muscles are within all those little joints of the body, but know that these really just have that action of supporting the foot there. So I think I have another slide, yes. Again, another view here of the intrinsic muscles of the foot. This is a nice picture here of the flexor hallucis longus and the flexor digitorum longus coming all the way down into the ends of those toes. And remember, the flexor hallucis longus is the thing that loops right there. It's taculum tali, so that's what loops right there. So that's kind of that point that we talked about before. But again, don't worry about memorizing all these different muscles as far as the origin insertion. But for sure, know the origin insertion of the ones as we go up into the leg that are part of those compartments. But just the intrinsic ones, don't worry about that, because that doesn't really apply to what we're doing here. We already talked about the retinaculum. The last slide, slide 45, that's on Blackboard here, gives you an overall snapshot of the arteries, veins, and nerves. We will be focusing more on the nerve innervation in this next test. I imagine there to be some kind of a matching section where you need to know the nerves in greater detail than you did in the spine one. So do pay attention as you're reviewing that you need the origin action insertion as well as the innervation or nerve supply. So please make that a focus and priority in your studying. All right, I think that covers it for the foot. So like I said, glad that you were able to review this way. We'll follow up on Tuesday in class and see how you guys feel with the foot type stuff. All right, talk to you soon.